Welcome to the Everything Surgery podcast, where today we will be delving into the SCANDIV trial, published in the Journal of the American Medical Association in 2015. Let us start with the main objective of this important study. The SCANDIV trial set out to compare two surgical approaches for the management of acute perforated diverticulitis with purulent peritonitis, also known as Hinchey stage 3. Specifically, the researchers wanted to evaluate laparoscopic peritoneal lavage, which involves washing out the abdominal cavity without removing any part of the bowel, against the traditional approach of primary resection. This traditional approach could be either the Hartmann's procedure or a sigmoidectomy with anastomosis, where the diseased segment of bowel is surgically removed. This was a multi-center, randomized clinical trial conducted in Sweden and Norway. The study enrolled a total of 199 patients, all of whom had a clinical suspicion of acute perforated diverticulitis and required emergency surgical intervention. Participants were randomly assigned to one of two treatment groups. The first group, consisting of 101 patients, underwent laparoscopic peritoneal lavage and drainage, meaning their abdominal cavity was washed out using minimally invasive techniques, but no bowel was removed. The second group, containing 98 patients, received the standard surgical resection, either through an open or minimally invasive technique, with the choice between Hartmann's procedure and primary anastomosis left to the discretion of the surgical team. The primary outcome the investigators were interested in was severe postoperative morbidity, defined as complications classified as grade 3 or higher on the Clavien-Dindo scale, occurring within 90 days of surgery. This included the need for further operations and death. Now, let us look at the key results. The rate of severe complications was 29.7% in the lavage group, compared to 32.7% in the resection group. The difference between the two groups was not statistically significant. Mortality was observed to be 12.9% in the lavage group, and 20.4% in the resection group. Again, although numerically lower with lavage, this difference did not reach statistical significance. When it came to the rate of reoperations, 22.8% of patients in the lavage group required additional surgery, compared to 28.6% in the resection group. The average length of hospital stay was very similar between groups, at 12 days for the lavage group and 13 days for the resection group. However, it is important to acknowledge some major limitations of the SCANDIV trial. There was a high rate of crossover from the lavage group to the resection group, with 24% of patients overall and up to 40% at one participating center ultimately requiring resection despite initial lavage. Additionally, the study was underpowered due to slow patient recruitment and early termination, which may have limited the ability to detect more subtle differences between the two approaches. In conclusion, laparoscopic lavage was not found to be superior to surgical resection in reducing severe postoperative complications for patients with purulent perforated diverticulitis. The study did not demonstrate a clear benefit for lavage, in part because of the high rate of treatment failure requiring a salvage resection. The clinical takeaway is as follows. Laparoscopic lavage may be feasible for select patients, but it carries a significant risk of treatment failure and the need for subsequent resection. As a result, surgical resection remains the standard of care for purulent peritonitis in many clinical guidelines. Nonetheless, lavage could be considered as an option in highly selected, stable patients when experienced surgical teams are available. Thank you for tuning into the Everything Surgery podcast. If you enjoy our content, please like, share, and subscribe. Until next time, keep dissecting the extraordinary.